why would we even need to go to another country to source the same medication?
No, that's the right question.
Yeah. Okay. Finally, I asked the right question after half an hour. Why though? What's the point? Hey, what's up, guys? Spencer Smith here, host of the Self-Funded with Spencer podcast, sponsored by Pareto Health, ClaimDoc, and PlanSight. Enjoy today's episode.
Right, and that's the paradox on the broker side. I've got 100 things I could talk about. When do I talk about that?
This one, yeah. Well, I mean, even it may or may not generate an ROI, but it may take years because let's say you have 1,000 employees and it's $300 a test. It's one time, but that's 300 grand you just spent. How long would it take you to recoup $300,000 through low-cost generics? And
you probably won't test everyone. You'll test only the folks that are currently on a treatment like that.
Okay, fair enough.
Right?
Yep.
Or begin a treatment like that.
Fair enough, yep.
So maybe it's 10% of your folks. So 30 grand. Right?
Yeah.
And so, but even there, it might take you a hot minute.
Still, then you think that is a feel-good thing, though. It's like, here, guys, here's why we're going to pay for this. Here's why we want you to use it. We want to make sure that not only is your experience optimized, but your health. We're thinking about your health. And if we can prevent you from taking a drug that would negatively impact your health and doesn't do any good for you.
Where I think the PGX market could go, and maybe it's there already, but if it could apply to the autoimmune diseases and where the specialty drugs begin to be treatments, that's where the ROI would be so fast. Because we'll see a lot of folks jump in drugs, especially in the biologics. They only work for so long.
Okay.
And then they stop, and then you got to change, and then you got to up the dose. And it's like, okay, well, what if we fast forward on those, and this is the treatment that works best for you? Let's start there.
Yeah.
It's still expensive, but we're not having to waste money on all the other stuff that never worked before.
Well, waste money and the time, right?
Of course.
Shorten that time frame.
The patient.
Yeah.
Well,
I'm the one being experimented on right now. Yeah.
Still suffering through treatments and shots that never worked for me.
Yep. Okay. So I'd say you're optimistic about the application of pharmacogenetics.
I'm very optimistic.
Yeah.
I'm nerd out about that type of concept because I see what it's done for me, just genetics understanding in general.
Okay.
And I know what it can apply. We just have to find a way that there's an appetite for that and it doesn't compete against everything else that we're trying to accomplish and a broker needs to accomplish for their client.
Yeah, fair enough. Well, I said it's a good place to start, Nathaniel. I figure we're good to go. All right, so cool. We'll kick off the podcast. We may even leave a splice of that in here because I think it may be relevant to the rest of the convo. But I'm here with Paul Pruitt, who is the Chief Growth Officer of SHARx. What's up, man? How are you?
I'm doing great.
Well, thanks for coming in. I know you had a pretty easy travel in and hopefully an easy travel back from Colorado Springs, right?
Absolutely, direct flight.
Direct flight, man. Well, I'm always gracious of folks flying in. You and I, we met at a conference a handful of months ago and just happened to be sitting in the same table. And I said, I've heard of this SHARx thing and I don't know anything about it. And you obviously were more than willing to tell me about it. And then ultimately that led to us having you on. But Paul, before we get into all the stuff about SHARx, could we hear a little bit of your backstory and who you are a bit?
So obviously I'm a partner and founder, co-founder of SHARx. And so my backstory, I was actually on the broker side and was living this world and managing clients and being just as frustrated with medications chronically raining right on my parade and when going through the renewal process and having lasers and stop loss and all the things I know that happen today, happen even more frequently. And my business partner called me and said, hey, I have this crazy idea. We're working with individuals on accessing high-cost medications from very creative strategies. Could this work for employers? And it was like, absolutely. Please create that. I need it for my own clients.
Yeah. Well, that's funny when you get those calls about the crazy idea. You said this actually was a good crazy idea, right?
Absolutely.
It's so crazy it worked.
That's so crazy it worked.
Yeah, that's funny. But so you were a consultant, though. You kind of you touched on that a second, but I want to go back to kind of the consulting days because I think the consultant, obviously a lot of the folks that listen are consultants, but you're in the best position to understand the good and the bad in our industry and see what works and also understand maybe some of the dark arts and some of the things that aren't so effective for the user or the employer. But tell me about your time as a consultant, how that introduced you to this industry and sort of your progression ultimately that led up to SHARx.
Sure. I started in a small boutique firm and my business partner today, he was the co-owner of that organization. So I cut my teeth just learning They were very creative, and so to me, that just became how we do things, right? We're always outside of the box thinkers, bringing new ideas. That was how we differentiated ourselves from a lot of the bigger houses. And about 5 years into that, we were acquired by a large agency. And then, I moved to, then I left about 2 years later. I started my family, moved from St. Louis to Nashville. And that's kind of where I ended my journey on the consulting
so
side.
you moved to Nashville before it was like really cool to move to Nashville then, right? Like, because I feel like everybody during COVID went to Texas, Nashville, or Florida.
I grew up there.
You
so
grew
I was
up
just
there.
going
Okay.
back home. Yep.
Okay. Very cool, man. So started a family. And then, so you sunset ultimately the consulting side of your career once this crazy idea was introduced to you, right?
Absolutely.
Yeah.
It definitely, as this became a very passionate for me to say, hey, this is awesome for my clients, but what about all the other employers that I know are having the exact same issue?
Yeah.
And what wouldn't it make more sense to be more of an evangelist for this idea nationally versus just bringing it to my own clients?
Fair enough, yeah. And then I do want to dig into, obviously, ultimately what SHARx does, and I think that would be the bulk of this conversation. But over coffee, you mentioned to me there's kind of like a personal reason why you're so passionate about this, and probably helped us uncover the why you do this. So would you mind sharing that? Pareto Health is the manager of the largest employee benefits group captive in the United States. And it's also now the main sponsor of the Self-Funded with Spencer podcast. I chose to partner with Pareto Health for three main reasons. Number one, their dedication to improving the world of health benefits. Number two, their mission to reduce volatility and to make self-funding simple for mid-sized employers. And number three, the strength and scale of their program. With over 2,300 member groups and more than $1 billion of stop-loss premium under management, Pareto Health is the most robust solution of its kind in the country, period. Stay tuned for more information because I'm sure I'll be featuring them on an episode of the podcast very soon. Visit Pareto Health at paretohealth.com or follow them on LinkedIn to stay up to date on the latest news and developments.
Absolutely. So, as I had moved to Nashville outside of my family, we found out a few years into that my oldest two boys had a rare genetic condition themselves.
Okay.
And so that quickly thrust myself and my wife into kind of a hyper user of healthcare mode versus a health insurance architect. And that was very eye-opening. We had the good insurance and all the big names, and it was frustrating how lacking anyone from the hospital, social workers, case managers were in actually giving us what we needed help in. It was, hey, I need help with my medications, and how do I get those? And well, we don't do that. I'm like, well, what do you do? So we had to do a lot of personal growth and talking to other family members, and that was where I really learned a lot of tips and tricks and things I'd never heard about just going through this journey. So now, luckily, my kids have medication that treat them, so they're doing great. But it's about $75,000 a month for each boy.
$75,000 for each boy.
For each, so that's
$150,000. Yeah.
$1.8 million a year.
Okay.
In medication expenses for my family. January 1st, we know what's coming.
Yeah.
Right. So this was a very, when my business partner approached me for SHARx, it was, hey, do this, and I know how much this will be a big impact for the individuals. Not only do we understand more of the tips and things that are available that most people aren't aware of. Yeah. But also when those are leveraged, right, the individual member now has, someone gets it, someone understands me, because everyone's on their own figuring it out. And it's a very hard, I do this for a living, my wife's a nurse. If it's hard for us, it's hard for anyone. Yeah. And didn't you say even to this day, you're still spending hours, like a month, like going through the filling process and things like that? I mean, absolutely. I mean, it takes hours and hours just to refill a drug that you just filled last month. Which is just more of a testament to the systems that we're using aren't designed for me, the patient. It's built for everyone else and what's important to them. Sure. But not what's important for me, the user of the medication. Well, you should be so lucky that you get to pay them $1.8 million a year, or obviously I don't know what your coverage looks like, but that's kind of the way they treat it, right? It's like, yeah, here's this orphan drug that has one specific application. We're the only ones that deliver it to you. Here's the price tag, and we're going to make you jump through a bunch of hoops to get it, right? Like, congratulations. On being able to be a user for us. But so I guess it doesn't take a lot of effort for you to get out of bed in the morning and know what you're doing for the industry, because you're impacting your own family, as well as obviously being able to do this at scale. So walk me back a little bit. As this crazy idea,
you said, hey, that's actually a really good idea. And you sort of formulated it within the framework of that business you built. And then I think you said you ultimately kind of divested and turned it into its own thing. But can you tell me about the early days of SHARx?
Yeah. So when SHARx was created as an idea, it was really it was for members that enrolled in the health share community, right? Health shares don't have coverage for reoccurring events. Medications aren't normally a part of what's shared in those ministries, and having a solution for those members when they do need a diabetic medication or some need shows up eventually, which normally what happens, how can they continue to be enrolled in a service like that? And so that's ultimately where the SHARx idea was created. And the reality is that employees and the employers that sponsor those plans are suffering in their own way. And what can we do to bring that service more at a scale for a population that works for an employer that may not be able to continue to sustain that type of burden on their health plan.
Okay. Well, tell me about the mechanics though, as you sort of like turn this into its own company, right? And then is the health share ministry still even in existence, or has that been sunset at this point?
Yep. So a few years into where SHARx was more of a product of the health share ministry operation, it made a lot of sense because it would create confusion. Well, who's that company? I thought this was SHARx, and so we created a standalone company for SHARx, so that it had its own operation and business and contracts, and the health share service is no longer. It became more of a fight than anything. A lot of the states really hate it.
Yeah.
When you're trying to serve members in a more affordable way, they like insurance.
Yeah.
Because that's where taxes and things come in. And so it just became too much of a fight politically and legally for that organization to sustain itself. And this seemed to have more of a future. Yeah. And was important enough to focus all of our efforts and minds and from an ownership group into this service. So this is the platform that we're moving forward with as an organization.
Well, so that's a good segue then to the platform itself, right? Let's go ahead and define it, because we spent about 15 minutes or so chatting, and I think a lot of people have heard of SHARx before, myself included when we had our initial conversation, but I really didn't have a grasp of what SHARx is. So I want you kind of in your own words, at least to lay the foundation. What is SHARx, as I ask some follow-up questions?
Yeah, so SHARx is a medication procurement optimization platform, right? We're an ecosystem of best practices that all really come together when insurance is not in the way.
Okay. And you said that this is kind of for employers that have thrown their hands up in the air and said, I'm done with the insurance side, right? It's like these people somewhat either on their wits end or just absolutely looking for something different than they're being offered today, right? So what does that mindset look like, or what is an employer dealing with that ultimately leads them to a SHARx?
Yeah, I mean, I know, but I think through a lot of the clients that have asked us to work with their people, their attitudes have been, hey, this is something we can't sustain. We've kicked this can down the road as long as we are able to, but at some point, we're not able to offer great benefits and even maybe run our organization anymore if we can't solve this problem.
Okay.
And we have got to look at it from a different angle, and we're fed up from how we're taken advantage of as an employer, our members, how they're being taken advantage of, and the attitude has generally been, we can't do this anymore. Can you help us? Because our people matter.
Yeah.
And sometimes employers I just don't like being bullied, and and whatever I can do to get out of that environment or fight back against the bully, like that's also an attitude that we've seen be very successful for employers to say, this is enough's enough, and how do we fight back against this, because everyone else is winning at our
own expense. Yeah. And I mean, that's the contrarian mindset, right? You get so frustrated, you kind of say, well, screw you. I'm actually going to stand up for myself. I do think our industry has done a disservice to a lot of employers in that they train them to sort of be dumb, or train them. Dumb is probably not the right word. I don't want to suggest they are dumb, but train them to not really know what else is out there or seek guidance. It's almost like, hey, here's your renewal. I negotiate a little bit. Yeah, we'll strip a couple things out of your plan design. I'll show you another carrier, just have something on a spreadsheet. Yeah, we're going to take this 13% increase because it's the best thing we can do. And then they move on 12 months from now and have the same conversation, and nothing really gets done. I think the industry has done a great job of suggesting that's actually the outcomes that the majority of people have to accept. And you're obviously looking for those employer personas that say, no, absolutely, I know there's a better way to do it. and I want to do something about it. So is that usually stimulated off of a really high cost medication, like in your son's circumstances, or is it a multitude of things? Like what gets somebody to that point?
Well, and I think high cost is a very relative term.
Okay, fair. Yeah.
Yeah, no. Yeah. So like $1 million or $2 million medication, like what we come into, may not be a big deal for certain organizations, and it may be, it may be the difference between staying in business or not, or maybe having to go back to fully insured, because who can afford something like that if you're self-funded? I mean, it's a destructive environment, and in my position, we see the drugs like this all the time. So I would say when it's painful enough that it creates worry. We've got clients that I know that have told us that, they were losing sleep at night because they didn't know what they were going to do.
Yeah.
Because they cared about their employees, but they may not be able to stay in business if they don't figure out this problem. And it wasn't because they had $1 million drug. They just had enough problems where it was ruining their business.
Sure. So then as they get introduced into the fold, I think it's probably a basic question, but I should ask it. SHARx is not a PBM, right?
Correct.
Okay. Because sometimes I think that even the misnomer or misconception is out there. So you're working either in conjunction with an existing PBM or just ultimately on your own, correct? Or as a complementary piece, if you will?
Yeah, I would say we're always a part of, we want to connect with our PBM partners just as a way to share information and be a very easy transition for an individual. So that's, a PBM is really more of an administrator, right? They're going to adjudicate claims, have a network, have the rebate part of their comment. All those important parts of a PBM still exist, but for most of the medications, where when an employer does make some plan changes and exclude certain items on the health plan, right? That's where we kind of are tagged in.
Okay.
But it's part of more of that adjudication process, the PBM, to say, hey, SHARx, here are some members that need your help. Reach out to them.
Yeah.
And so we see that through our integration and data sharing.
Okay.
And so they perform their role, we perform our role, but we work together so that the members don't have to be taught anything new. Yeah,
because obviously anytime you introduce more vendors, right, the fear is, does this work together, right? Is it still going to be streamlined, or do I have another administrative burden placed on me? I mean, all these things that obviously are knee-jerk reactions, right, when something comes into the fold, but your job is, of course, to make sure that there is no loss of interconnectivity or interoperability is the word I really like.
And I've done those things when I was on the consultant side. I've put in standalone, siloed services, and they don't really have the legs under that you wish they would, because the member has to do a separate thing.
Yeah. Yep.
And so when we can become just a part of the ecosystem, the part of that patient's journey without teaching them anything new, we just can gracefully grab their hand and bring them our way. That's where this begins to work the way we all want something or want it to work without having that fear of interoperability.
Yeah. When you say, another misnomer I think we discussed over coffee is that you're not just a specialty carve out, right? And that was even a misconception I personally had. I was just thinking specialty medications alone. And you said, obviously, your threshold is much lower than what I consider specialty, and then also a lot broader, right? It could theoretically be almost anything. So tell me why or how it's not just a specialty carve out.
Yeah. I mean, the reality is almost any chronic medication can be procured and sourced more effectively than what is happening today through insurance.
Okay.
The reality, though, is for an organization like mine, there's only so many things that are, let's call it, require the touch and the handhold and the concierge service that we provide. And so we try to create maybe an ideal threshold for where that becomes.
Okay.
And so for, even branded medications and insulins and asthma medications, right, to an individual, those are still expensive. They have high out-of-pockets, especially if you're on an HDHP type of health plan, right? You're dealing with, $400 or $500 a month. That's expensive to me, the individual, and it's something that we can still solve on their behalf. And for a lot of employers, that going to that level is worth it because the member is grateful. The plan is benefits and all parties benefit. And it's not about just focusing on the easy big stuff or the specialty medications. While those are important, there's still more that work we could do, and that's why we build our plan around like what's the most impact that we could have for the right population.
Yeah, kind of a utilitarian approach almost. So then how do you work with each individual employer to say where that threshold is set? Like, are they working, do they have that level of customization with you to do that?
They do. We have some, let's call them defaults or what we might call a best practice.
Okay, yeah.
Right. Hey, this is what works well for most employers. Sometimes they do want to customize that, and we have some flexibility on how they want to run their plan and how we can support them in that. But for most employers, they kind of look at our best practice and go from there.
Okay. And then so like, what's the trigger, right? Because if you are working in conjunction with the PBM that's adjudicating these claims, right? How do you become aware, or how do you guys get involved? Like, what does that step look like?
Yeah. So what so we actually get a claim file feed every single day, and what we're looking for are those rejected claims, right? What didn't?
Okay.
What medication did a member attempt to fill that would fit in our scope of work that we've been tasked to work on, and that triggers us to reach out, say, hey Spencer, I see you recently attempted a medication that needs to come through us because it's not covered by your health plan. Great news, it probably won't cost you anything when you work with us. So once you come on board, it takes 3 to 5 minutes. It's super easy. You can do it right on your phone. So we want the message to the member to be a very welcoming and warm message, not punitive in nature, but also like, hey, this is urgent. We really want to help you.
Yeah. Yeah, because if initial, like maybe the first time it happens, that person's going, wait, my medication's not covered anymore, or they won't fill it. What's going on, right? So there's probably a little bit of fear.
Well, not necessarily. We think about, let's say, a brand new person. If you roll up and try to fill a special medication, well, you're not getting it today. Because why? You can't fill it here. You got to fill it here.
Yeah.
You got to do a PA, right? There's already these built-in hoops you have to jump through with the insurance model. And so what we're trying to do is intercept that and make the whole process even easier than what the insurance is going to make you do anyway.
Yeah. Okay. Well, that makes sense, right? And it's just really about intervening as quickly as possible, and then and also showing them what the incentives, right, to them, put the potential for zero out of pocket, right? You can fill it over here. There's no difference in the drug itself. So you're still benefiting, but hopefully the idea is to drive down costs simultaneously. But you mentioned it's not covered by the health plan. So I want to talk about that, right? Because we touched on earlier, throw up my hands and say, screw this, I'm out. I don't want to cover this stuff anymore. There's got to be a better way than this big bad insurance. So when you say it's not covered, how is it separated, and then how are you guys providing the backstop? PlanSight is a complete game changer in the world of insurance brokering. As a broker, you know how time-consuming and error-prone the traditional RFP process can be. But what if I told you there's a better way? PlanSight is the only end-to-end RFP solution on the market made specifically for benefits agencies. It's like having a superpower that gets you an average of 8 to 10 hours back per employer renewal per year. And the best part? PlanSight supports all carriers, all funding types, and all group sizes for over 20 different benefits. If you're ready to make your RFP process faster, more efficient, and more profitable, it's time to call PlanSight. Visit plansight.com now to book a free demo and discover the future of insurance renewals.
Yeah, so I think that's part of the first change that an employer realizes is using insurance for known, repeatable, high-cost events. It's how we got here.
It's not the reason for insurance in the first place.
It was never designed for that. Insurance, the concept, was built to manage the risk of unknown loss. And when we think about these routine expected events, it breaks the mold. And then when you layer in really expensive items on top of it, it just compresses those prices upwards. Yeah. And so what we think about is, well, if insurance isn't the tool, then what is? Mm-hmm. Or the other way around is, well, what if I stopped using insurance for this issue? What else is possible? And that's where the aha moment comes into is, wait a minute, my people don't really like it. It's burdensome. For my own story, I've seen that. And as an employer, I really don't like what this is doing to my budget. And if I got out of it, does that make it does it liberate both parties from the burden of insurance? And that's really what we've seen is removing that barrier to access. Right? Cost is often a problem for members at forwarding their drugs. Using the systems that are designed around the insurance machine aren't for them. And so what if we took all that away and made everything simpler? Yeah. Right now I'm doing it for my employees, liberating them from the burden of insurance, and everyone now can benefit because we're now using the right tool for the problem instead of insurance, because it's never built for that. Yeah, and I would say you're speaking my language there, right? And I think look at like the direct primary care model is a great example, right? There's an idea, or the notion that those regular, reoccurring, relatively small routine claims should have never been covered by insurance or should not be covered by insurance at this point. So if we bucket them over here and turn them into a capitated fixed cost, I've taken it away from insurance,
theoretically the physician is happier, the employee is happier, and the employer is happier simultaneously.
Right.
Imagine that, right? So like I'm actually being a stop loss guy, it seems sort of counterintuitive, but I'm an advocate ultimately for less insurance application overall because there's so many things that just get forced into the equation because then you can roll them up and turn them into a higher aggregate cost and then have a reason to say, well, this is why your premium's going up simultaneously. And so I just, you're speaking my language here because it sounds like you have the same mentality, just applying it to the prescription world instead. But does the employer then go, well, hold on a second, like I'm worried now. Like, do they have a little bit of concern that insurance isn't covering it anymore? And so how do you provide that reassurance or walk them through why that's not a concern?
Yeah, so the first place is to really understand what's today look like for an individual. How are they getting what they need now? What's that journey? And what does it look like when we take insurance away and now what's possible?
Yeah.
Right. But if you don't understand today and you just think I have good insurance, everyone's getting what they need all the time it's like, well, it doesn't work that way.
Yeah.
Right. We wished it did, but none of the players that we have involved are built for that to be true. Right. And there's good reason, if you're going to pay for a drug as an employer, you don't make sure it's is it necessary? Is it reasonable? Is there something better they could take? Like those are the right questions. But to the individual, those are annoying questions.
Yeah.
Right. But
I just need my medication. My doctor
prescribed this and I want it.
Yeah.
Right. That's the attitude of most people. And so that's what we're trying to help them help them see is like, look, this is how it works now. I mean, this is how it could look. Right. This is this is the feedback we hear from employees where they actually pick up the phone and they call HR and say, you know what, thank you for putting in SHARx. I was having to pay a couple $100 a month for my medications. Now they show up at my door for free. And this is a blessing to me that a service you've done for me that's a blessing. Thank you.
Thank you, yeah.
Now I can say as a broker, I never heard of an HR person getting a phone call of thanks. If HR got a phone call, what's wrong, what's broken? Hey, broker, fix this for me, right? That's always the path. And now we're hearing gratitude's being shared. And for people to take the time to say it, that means it must be, that's how powerful that is.
When I say also adding a little bit of like visibility for the employee to understand like the order of operations for that drug to be filled, right? And have some awareness, because like you were saying earlier, if I see a billboard that has a person smiling holding up their Buka card, right? And I'm all covered, I'm so happy I'm covered, right? You sort of made them think that everything is taken care of because you hold this insurance card in your hand. In reality, that drug was probably costing them a lot more money. There's multiple people that have their hands in the jar taking a slice of that. And the member, like you said, or the employee at the end of the day is the last person that's really any concern given to. And so I don't think they know that. Most people don't know that until they've actually had that hood lifted up a little bit and get a chance to see. I want to talk about a couple different directions here, Paul, if we could. I think of two things when I think of what you do. There's patient assistance programs or PAP programs that are often talked about. So can we spend a couple minutes on sort of defining what that is, how that works, and then maybe how that falls under your purview a little bit?
Yeah. So a patient assistance is really designed and you qualify in two ways. So remember, not everyone is eligible for this. So the first question is, do you have insurance? You either uninsured, means I have no insurance at all, maybe I'm in a health share, maybe I have nothing. Or I'm underinsured, means I have insurance, but not coverage for that particular medication.
Okay.
Then the next step would be, do I have, or do I meet a certain income threshold? And the general rule of thumb is normally the higher the cost of a drug, the higher the income limit becomes.
Yeah.
And in our experience, most employees on a specialty type medication qualify via income, and because the employer has elected to not cover the medication, so they're underinsured.
Okay.
And they do, and a lot of the folks will qualify, but not everyone, based on the income.
Okay. And this is a government program, right? So they've basically
Nope,
it's not.
Program.
Oh, okay. So tell me about that.
Yep. So this is where the manufacturer either offers a drug directly or donates medications through a foundation on behalf of the patient, right?
Okay.
So there's no government assistance. That's not really an avenue that the government plays in, nor should they, right? That's Medicaid or Medicare. And so we're really dealing with the manufacturer and cutting kind of everyone else gets out of the way. Hey, manufacturer, hey, patient, you two need each other, let's talk.
Okay.
Instead of everyone else being in the middle.
And is there a set number of dollars allocated annually, right? Or like, how do we know? Okay.
Yep. Nope. The manufacturers create the parameters for who's eligible. And as long as you're eligible, right, that medication, now they can update and amend and change terms of how their programs works on an annual basis. So as you come up for renewal, because every year you have to renew, if the rules have changed, that might impact you, but that's not common. But all of these things are always organically moving in the market.
Sure.
There's nothing static about this industry, and that's kind of why we are designed the way we are, because our goal is a member needs a medication, they don't have coverage. We have to find the best way possible to get to them what they need at the lowest cost available. If the manufacturer will give it to them for free, that's great. And if not, then we'll look for somewhere else.
Okay. And then let's say somebody does qualify. Ultimately, how long does that process take to play out?
It can take about 2 to 6 weeks from the time that a member onboards with our program. And then we reach out to their physician, and then when we submit that application on their behalf to make that process, because actually, when you're an individual, it can be quite difficult.
Yeah, for sure.
Because they don't want to give it away. But we understand all the check boxes that need to happen, what the doctor's part is, what the member's part is, what proof we have to provide with insurance, saying, hey, they're underinsured, and here's the proof of that. And that could take about 2 to 6 weeks to get approved, and most of that's how responsive the parties are in getting back to us.
Fair enough. Okay. And then the other avenue I want to go down, or anything else that you want to add on the PAP, because I don't want to skip if there's more to that side of things. But I think I hear a lot about that nowadays, right? And there's somewhat of a general lack of awareness of how it works and who qualifies and how to access it. And obviously, you guys are liaising throughout that process. But what else would you want to add on that before I kind of move on to another part?
Every manufacturer is going to have their own version of how it works. And that's where a company like ours is, we see that all day, every day. So we understand if it's on a certain medication, okay, great, what do we need for this? So you may, even the same person on a different drug, it's a whole different process.
Okay.
So people try to ask me like, well, how does it work? I'm like, well, which medication and what day is it?
Yeah.
Right? Because it's one of those, it's evolving and it never stays the same.
Well, and how often does a person that does qualify have to go back and requalify? Is it an annual thing? Okay, all right. And then so those terms are always moving, right? So you could qualify one year and next year, even though your circumstances didn't change, all of a sudden you don't qualify.
In our experience, manufacturers often make it easier as time goes on, but that's not always the case. Sometimes things go backwards.
Sure. Okay, so let's go down the other path that I wanted to talk about, which is the sourcing path, right? So people hear about either like sourcing drugs from, alternative countries, right? Or there's alternative methods of sourcing. So when you think about that term, and I bring that up, like what does that sourcing term mean to you and to SHARx?
Yeah, for me, I think it really leverages, let's call it the open market or the cash market.
Okay.
Right. So even if you think about the medical side of the equation, if we can go there for a second.
Sure, please.
Right. So like, hey, if I go to the doctor or hospital, there's often a cash price, right? That's different than insurance, it's different than the government might pay, but there's something that they say, oh, you don't have coverage for this. All right, well, here's your price. It's normally always cheaper than the insurance price, magically. But there's a cash market for that. There's the same cash market for medications, but you just have to know where to look.
Okay.
And so that's what our team is trained on, is to know where is the most affordable place to access any given medication for that member in the open cash market, because insurance is not on the table.
Okay, I got you. Okay, so then talk to me about the foreign sourcing, right? If we could just start there, right? So what countries are typically drugs coming from, if not the United States?
Yep. So when a member does look to do importation for themselves, they're generally looking at Canada.
Okay.
There are other countries that I know other vendors have used or that are also possible. They're generally the tier 1 countries like New Zealand, Australia, England. But logistically, Canada is simpler because it's the closest neighbor we have, and it's much quicker shipping times and things of that nature.
Yeah. But I mean, like, why would we even need to go to another country to source the same medication?
No, that's the right question.
Yeah. Okay. Finally, I asked the right question after half an hour. Why though? What's the point?
Yeah. So the problem in the U.S. is that the supply chain is so manipulated and broken, from manufacturer to wholesaler, from wholesaler to the pharmacy, from the pharmacy to the patient, and then eventually the manufacturer kicks a bribe or rebate back to the PBM for position on the formulary.
Yeah.
Right? So it's this pay-to-play mentality that exists in lots of industries. But the hard part is, as a patient, as a member that needs a medication, there is no cheaper way. It's expensive through the supply chain, and only at the very tail end, after you've already paid your price, does the manufacturer do a kickback later.
Okay.
Right? So I never get, as a member, get to reap the reward of what that rebate looks like. And so when you go to another country, they don't have those games. You got socialized medicine in Canada, for example. They can negotiate with Big Pharma. They don't have PBMs. They don't have all the things that are influencing or hyperinflating the retail cost of the drug. So you can truly just have a more fair, what is a fair cash price for medication? And that's why that exists in other countries. It doesn't exist much here. Now that's micro turning a little bit, like Mark Cuban's company just came out with a biosimilar for Humira.
I saw that. Yeah.
Because they're bypassing that channel. They're going manufacturer to pharmacy, right? And they're delivering it in a cash market, no insurance. Right. Someone's got it, and they're leveraging the right commercial principles in the cash market to offer an affordable product. We want more of that.
Yeah. Well, what you're describing, I think of the dealership model in the United States, but I think even to buy a vehicle, you cannot buy a vehicle from a manufacturer in the United States, right? So you have dealers. And we can go pros and cons of a dealer, right? But ultimately, that dealer is going to mark up that vehicle to a certain extent from the price that they bought it and then sell it to the consumer. Now, they might say, hey, well, I'm going to teach you about it. I've got great salespeople to understand the vehicle. We can get you financing. We can get you maintenance plans. We get you all these other things. But all of it ultimately leads to an increase in the cost. Whereas some consumers might say, I know what car I want. I've researched it. I want to go to Ford and buy that car directly from Ford. You're kind of describing a similar circumstance where there's 2, 3 additional layers between the manufacturer making a product and the consumer buying that product. And inevitably, it's more opaque and it's more expensive in order to do that, right? So it's really weird when you start seeing parallels in other industries that are mostly a result of regulation and lobbying and shocking, right? But I found prescription to be more and more fascinating the more I understood about it. I kind of kept a pharmacy at arm's length for a long time because I'm like, this is too complicated. There's too many players. It's too lacking in transparency. I don't even want to know about it. But the more I dig into it, the more I see how broken that system is. And obviously that's why you exist. I think the reason I reconnected with you and ultimately wanted to talk is this announcement, though, in the marketplace about a manufacturer ultimately was saying they weren't going to honor, they weren't going to allow these carve-outs to exist anymore. So I want to give you an opportunity to talk about that in your business and how whether that impacts you positively or negatively, but your perspective on it.
Yeah. So
could you first, so I don't dance around it, what happened, just so in case some people aren't aware, what was the announcement?
ClaimDoc is a medical claim auditing and member advocacy company. We provide fiduciary services to employer-sponsored benefit plans, and allowing them to create an environment where we ensure that the benefit plans are being charged in a fair and reasonable basis.
My business is basically people, and it become a real simple transition. We thought it was going to be far more complex. I've saved, we'll say, hundreds of thousands of dollars. I could not say enough about ClaimDoc.
Yep. So this year, a manufacturer, AbbVie, brought suit against someone in this space, a payer matrix. And, they made a lot of allegations and claims towards them, certainly very upset about the practice that a payer matrix was using with employers to circumvent AbbVie's profits.
Okay.
And so don't blame them, right? Manufacturers have an obligation to their shareholders to generate value, and they're often really, really good at that. And what had preceded that, though, was earlier in the year, AbbVie had changed the terms of their PAP process. They said, hey, if you have insurance and you're using a service like that, you're not eligible for our program. And but even before that, they were denying everyone.
Wow. Okay.
It didn't matter if the doctor sent a PAP in, denied. If the patient sent a PAP in, denied. If the patient was enrolled in a PAP and then subsequently tried to renew it or just change their insurance, denied.
So what was their grounds, though, for doing so? I mean, other than we don't want to, right? Like, did they have some sort of legal stance as to why they were making all these denials that you're aware of? Okay.
Nothing I'm aware of.
Okay.
But it's their program. They can change the
Okay.
rules. That's kind of the point, that they want to.
Okay.
So once we saw any of our members were being denied, we immediately were like, hey, we never want anyone being denied, and we transitioned away from that PAP program from that manufacturer because there were no approvals so there's no point trying.
Okay.
Some of our competitors kept trying anyway, because that's the only way they make money is if they get those approved. That's not how we make our money. And so it just became, so it was an easy, like, great, that doesn't work, try something else, right? Because our members need the drug. They don't want to sit through a process, get denials. No one likes that. It's not fun at all. And so the second we saw anyone was getting medications denied, it was, okay, great. What else can our members have access to that they can, that is available for them?
Well, ultimately, do you think that is it a lawsuit that's been filed so far?
It's a lawsuit.
Okay, so was it AbbVie filing suit or is it a countersuit?
It was AbbVie filing suit.
Okay. Do we know where that stands? Like, obviously that's probably going to play out over a long course of time, right?
It will play out. The last I heard was that there was a motion to dismiss and it wasn't granted.
Okay.
So I believe that it will go to a jury trial and.
Yeah, I mean, time will tell, right? I just think about like the sentiment, right? If I'm a person or a consultant or an employer looking at that, that would anger me at least that suit was filed in the first place, right? Because really what it seems like they're punishing is somebody using their program, right? Or being effective at using the program. But you probably have a different perspective.
Yeah, I mean, when I read the suit, it was a lot about some of their complaints were centered around you're profiting on my profit. Right, they're charged 25-30%.
Okay, because of the percent of savings.
Like, well, that's my money,
yeah.
And you're charging it, and you're not disclosing to the employer how you're doing what you're doing, and what happens if it doesn't.
Okay.
If what if we don't approve it? What happens next? And so that seemed to be a lot of the beef they had, or at least one of is like, hey, that's my money, and you're siphoning off my profits into your pocket.
Yeah. Well, that's always that delicate balance because there's a PEPA model and there's a percentage of savings models and a lot of different solutions in our industry. But it's a delicate balance of like, was it better for the employer as a percent of savings because nothing's theoretically being paid up front at a fixed cost? But then what's the threshold that's reasonable before everybody goes, well, hey, you're making way too much money? Or the PEPA model, which is, hey, we're not going to do that, but there is a cost associated with my business for me to operate, and so I have to charge you, right? And so I don't think there's an either or, there's a somewhere in between, a sweet spot, but it is a delicate balance to say, well, this is better, this is worse, and why? Because ultimately it's a perception issue, and it's objective, I guess I should say. But so then as a result, like, I don't think you view this necessarily as a total negative to your business, because what you're saying is your toolkit is a lot broader than simply just leveraging those programs. And so you go, okay, well, we'll just simply pivot instead of rather being undermined from our business model altogether, right?
Yeah, I mean, the reality is the problem's still here. The employers are still struggling. The members are still struggling, and there still needs to be an answer to that. I know that it's been relatively easy, or lack of oversight from manufacturers on how the industry has been operating, and so I think we always expected that to change, and we were ready for that. Just at least asking better questions on, hey, what is covered and what's the proof of that? But it's, a percentage of savings is a relatively simple sales practice, right? Hey, we'll try this thing, and if it works, you'll pay us less than you were going to pay anyway. That's easy. Now, I'd make more money if I did it that way, but it's not really. It doesn't start with the foundation of we got to exit this piece. There's no going back. Yeah, so there's no going back. And I want to kind of zoom out a little bit with you, although there's one more subject before we kind of go big picture, Paul. Gene therapy. It's something that we at Pareto think about a lot. Our stop-loss carrier partners are obviously sort of trying to figure out what's coming down the pike and how to pay for it and how to, change their manuals around, expecting a certain amount of these to be filled. But give me your perspective on gene therapy drugs in general, and then how are you guys preparing for some of these really, really large ticket drugs coming? Yeah, so several things about gene therapy.
Yeah.
First, those are medical claims, not pharmacy claims.
Okay.
And an employer can go down that path and say, hey, we also want to address the high cost burden of medication on the medical plan. We haven't talked about that today, but that's another avenue that some employers do want to address that piece, because they can be just as burdensome as a pharmacy dispensed medication. And those aren't really drugs, because if you think about how this works, you have an individual goes in the hospital. They often have to get some kind of treatment, irradiation of their of some certain cells, their stem cells. They send those off to a lab. They get tweaked. They go back to the patient. They get re-injected. It's like, and now it's a drug. It makes no sense to me. It's a therapy.
Yeah,
it's
even
a
my brain
process,
was
there's a
lumping it into drugs.
hospitalization.
Yeah, yeah.
And there's many. It's not just a one time. It takes, you're in the hospital a long time, right? It's an entire episode of care.
Okay.
But you slap a drug name on it, and so it's an odd dynamic.
Yeah.
And the reality is, when they're cures, no one wants to give them away.
Fair enough. Yeah.
Right. And
yeah.
so it's a different animal. I know a lot of employers had just said, hey, we don't cover these. Period.
Yeah.
Whether or not SHARx is involved or not. And so we'll do the best we can to help members that are impacted because of that, because that's just who we are. But there are different tools available to us for drugs like that.
Yeah. Okay.
Because they don't want to give the cure away. They'll give the treatment away.
Oh, absolutely. The whole adage, there's no money in the cure, right?
That's right.
But I've even seen some of the walking back of whether these actually are ultimately curative, or they might just have a longer horizon in which they're technically curative, but that we don't know that they're forever curative, right? And so therefore you have to go, well, should I spend $3.5 million on this possible cure that has a shelf life? All of a sudden dilutes the value proposition pretty significantly.
And that's a really more of, let's call it a clinical question.
Yeah.
That there are probably a lot of great vendors that are in that space.
Sure,
that's
sure.
not where we live.
Yeah. Yeah.
But those are the right questions.
Yeah.
Hey, we want our people to have medications, and a lot of the time we're dealing with some of these. They're orphan, when they're for orphaned up diseases like SMA. Well, these are kids, right? And if you don't treat it early, they may have to treat it forever.
Sure.
And the forever treatments are expensive, but for who?
For
right?
who? Yeah.
Because employees don't work at an employer forever anymore.
Yeah, absolutely, man.
Right. And so that's a much harder question, because we want to take care of our people. We would love for our these dependents and these children to get the cures that they need. But man, that price tag is very scary.
Well, that's what we think about in general. We talk often about how claims are increasing in size, severity, and duration, right? And so the duration component is what you were just touching on. Is not like these more catastrophic in nature claims or these ongoing conditions that require pharmaceutical intervention. They don't wrap up neatly for one stop loss carry policy, right? They're either ongoing forever,
right,
or they have a tail on them that might transcend one or two or three policies. And so whose burden is it, right? Ultimately, and then there's a shuffling of risk pushing back and forth between employer and carriers. And so it's one of those things that doesn't have an answer. It's just simply now another paradigm that has to be addressed. So let's zoom out, Paul, as we move towards the end of the podcast, man. I want to kind of just get your perspective. I always ask people to weigh on the big picture of healthcare and where they think we're going in the next few years. But let's drill that down for you. That's more pharmacy focused, right? Things that are keeping you up at night, things that you're looking at on the horizon 24 months from now of what you guys need to do. Tell me some of those things that you're thinking about.
Yeah, I mean, we're always looking for, as many tools to solve our members' needs as possible. And, we'll be coming out with some additional resources to make sure that we've got enough in our toolbox to address any need that's in front of us. Even if some of the existing markets dry up, get harder, close down, the problem
it's never going to go away.
Going away.
Yeah.
I don't believe that our government has an appetite to address the root causes of how we've gotten here. I think there's a lot more conversations happening around it, which I love to see. And maybe one day my company won't need to exist because there's a fair price for the medication and there's value tied to what things cost. I don't see that ever happening.
I doubt it. Yeah.
I wish it would.
Yeah.
But until then, we're here to fight the fight.
Yeah.
Because it's worth fighting, and the members need someone in their corner, and the employers, cannot continue this. And so that's, at least 2 years down the road, I don't see the problem getting any better. I think it's just going to keep getting worse. The entire pipeline of medications is these things, especially the really rare drugs that we're blessed as a parent. You're blessed to have something that treats your kids' conditions. Sure. But man, the profiteering that's not just allowed but applauded and encouraged in our country is frustrating But that's the market we have, and all we can do is kind of play within the confines of what we're given.
Yeah. Well, I think about that like wearing two hats, right? It's like you might not like what some of these companies are doing, but then you look at their stock price over the last 10 years and you're like, well, I should have invested in that company simultaneously because I'm not going to beat them. I might actively fight against them in certain isolated instances, but also you're right. The profiteering and sort of the profitability that they're delivering their shareholders is astronomical. And so then do you see that going away? No, because they have so much market share and so much power and money now. But as we land this plane, Paul, why don't you say, like, can we talk really quickly? Because I know consultants are probably listening to this. I'm sure a couple have been, their interests have been piqued. I'm sure they also have clients of theirs in mind that really would fit this. But like engaging with you to get this in motion on a case, can you walk me through a couple of those steps of what that timeline looks like and what's necessary to get you guys involved?
Yeah. So, I mean, so it can easily start with a conversation like we're having today and just exploring, what's going on, what are you seeing with your clients? What else have you been working with and are excited about in the pharmacy space? But ultimately where we'd like to understand is to look at a claims data set for a client and say, hey, how do we answer the question of what would look different if a client had SHARx and made some changes to their plan in the past? Mm-hmm. What impact would that have made for the members, for their employer group? And then what would it look like if we're here to assist and that employer does say, you know what, I don't want to play this anymore and I want out. But that starts with more of an exercise and an analysis, which that's probably the first step that we would recommend is say, hey, does this even make sense? Is there enough of an issue or concern that the employer has that we can be a fit for them, that we could be a solution for them?
Okay. And then, like usually this is something that is added on cycle at renewal, or can you guys get involved at any time?
From our perspective, we can get involved at any time.
Okay.
Right now, that's more of who are your current players, right? I might think about your foundation, and does your foundation currently support us? An employer making a change like that right now, or does that make more sense to do at an open enrollment? Maybe you have to change some players out for some players don't like what we do. The foundation and who the TPA or the PBMs might be today. And so that's more dictates when you could deploy a solution like ours.
Well, and I'd say like if you're not making a few enemies or a few ruffling a few feathers along the way, you're probably not making a big enough impact. And I think that's natural at being good at what you do or being different for what you do. So Paul, I really appreciate you. Give you 30 seconds if you want kind of closing thoughts to wrap up the episode. The floor is yours.
Yeah, well, I do appreciate the time we spent today and you inviting the questions you've had and love being able to share my story, because it truly is something that I think is why we do what we do, and we're passionate about this. It's not something we're trying to profit on the problem and get rich on. This is something we feel like is a sustainable solution we built the right foundation for. And so that's our quest, if you will. Our mission is to truly deliver the right value back for the members that truly need medications, and we want them to get what they need when they need it, and the employers that are saying, hey, I've had enough of this.
Cool.
And so those are who we're not for everyone, right? Some employers are cash rich. Some employers, love what they've got going on. They value that, and that they should continue to do that. And the ones that need out, and sometimes it's the smaller organizations, or 2, 3, 4, maybe some of the ones that are fit for captives are also the ones that say, hey, I want to go self-funded, but I can't take the risk of that thing. And what can I do to dig my level before I'm thirsty?
That's just it. We're looking for a persona, right? We're looking for the right mindset, just similar to you guys. I wouldn't argue that we're for everybody. And I actually think it would be a disservice to our members if we were for everybody, then, because you're diluting that value proposition. So Paul, love it, man. Really appreciate you coming in. Thank you. You educated me on quite a few things, like really opened my eyes and quite a few things that I feel like I'm going to be better now for it, man. So thank you for doing that. And I hope the audience feels the same, man. Talk to you soon.
Thank you.
Yeah.